afternoon, everyone. I hope everyone can hear me okay. My name is Arina D'Souza, and I'm a spine surgeon based in Germany. I'd like to welcome all of you all to this webinar. Thank you so much for joining us. It's an absolute pleasure and honor to have you all. As you would know, the topic we're talking about today is Ferticare and how it assists with ejaculation in men, especially in spinal cord injury, but those who have an ejaculation as well. And we're going to share the screen space with experts who are very well known in their field. And I'd like to welcome all of them. I'm quickly going to just put up the agenda. So we're going to start off talking with Darren, who's going to talk about how this works and what's the current evidence. We're going to have Michelle, who's then going to follow up talking on all the practical applications from her professional experience, followed by Mr. Amr Rahim, who will talk about the device, infertility, male sexual health, and we're just going to touch upon literature, the various uses. And last but not the least, we're going to go to Chris Dabbs, who will talk about his personal experiences and practical tips. It is my honor to actually introduce all of them. I'm going to just give you a brief intro. Darren is the managing director of iMEDicare, who is the sole distributor of Ferticare in the UK. Michelle is our expert sex and spine panelist, and she is a psychosexual therapist working especially in the field of spinal cord injury. She works with leading centers of spinal cord injury in the UK. Mr. Amr Rahim is our consultant andrologist working in London, who has great experience in this field, and he will be sharing his thoughts with us. Chris is an expert patient, and he's going to share his tips, tricks, personal experiences with us. First of all, a journalist, and an absolute pleasure to always talk to. So without further ado, Darren, I'm going to pass this on to you.
All right, guys. Good afternoon, and ladies and gentlemen, and thank you much for joining us. Right, so my name is Darren Breen, Director of iMEDicare Limited. I've worked in the medtech industry since 1996 after completing undergraduate studies in medical sciences at Edinburgh University. iMEDicare Limited is a dynamic and rapidly growing medical device supplier established in 2004, offering an exciting range of unique and market-leading medical devices for home patient use in the fields of andrology and continence management throughout the UK and Ireland. Some of these devices are by your patient's GP, but all can be purchased over the counter directly from iMEDicare. So normally we offer a unique blend of professional and patient product training in clinical and home environments, which are designed to improve individual product customizability, user uptake, and long-term patient compliance and satisfaction. Right now, under the current C19 circumstances, we are offering customer support by televideo, which appears to be working very well. So today we are here to introduce the latest and long-awaited new version of Ferticare, the 2.0 in blue, after a few years of hiatus in supply. Ferticare 1.0, aka the Personal, was designed and manufactured by hand by a Danish company called Multicept and became widely known across the world as a reliable device for achieving sperm retrieval in men hoping to achieve conception. Ferticare 2.0 is machine tooled and assembled in the USA by Reflex Onic LLC. Penile vibratory stimulation, or PVS, is considered the method of first choice for semen retrieval in men who are anejaculatory due to spinal cord injury, applicable when the level of injury is above T10, which means local ejaculatory reflex arcs are likely to be intact at levels S2 to N and T10 to L2. So anejaculation is the pathological inability to ejaculate in males with or without orgasm. Compared to the alternative semen retrieval method of electroejaculation, PVS results in better semen quality, is preferred by more patients, and can be performed by selected couples wishing to attempt home insemination. There is also good evidence that spasticity can be reduced from 2 to 24 hours after each PVS application. The physiology of ejaculation is a highly coordinated process controlled by sympathetic, parasympathetic, and somatic nerve systems. Normal ejaculation requires integration in the activity of the spinal cord segments T10 to L2 and S2 to S4, as well as supraspinal input, both stimulatory and inhibitory, to these cord segments. SCI may disrupt the normal nerve pathways required for antegrade ejaculation. Approximately 9% of men with SCI are capable of ejaculation via masturbation or intercourse. Thus, the majority of men with SCI require medical assistance to induce an ejaculation. High-frequency penile vibratory stimulation is an excellent option for patients with a level of injury T10 or rostral due to intact sympathetic and parasympathetic components of the ejaculatory reflex, as well as the dorsal nerve. The device is heavy and fairly bulky, but has a solid composition. It looks very well engineered with a nice blue color. It features a built-in lithium-ion battery that takes approximately 1 hour of mains charging to provide approximately 20 minutes of continuous vibration. It cannot be used whilst charging. The frequency range is 70 to 110 hertz, and the amplitude range peak to peak is 0.5 to 4 millimeters variable. A 1-year warranty is included with your purchase, which is valid for the original owner only. So the device may be turned on by turning the knob at the base of the system away from the body. This will increase the frequency in increments of 10 hertz. The frequency at any value between 70 and 110 hertz. The device is turned off by turning the knob back towards the body to the off position. When the vibrator is on the on position, a green light appears. The battery can be charged at the port indicated charge in with the adapter charger included with the device. The applicator pad should be placed to the dorsum top or frenulum bottom of the glans penis, head of the penis. The amplitude of pad oscillation can be increased by twisting the cap on the applicator pad side of the device away from the body, and conversely decreased by twisting towards the body. This takes quite a grip. To view the millimeter setting, see the amplitude indicator on the main body of the system. The amplitude may be set at any value between 0.5 and 4 millimeters. The power charger for the device contains a standard adapter with a 12.6 volt DC output voltage. It will light up blue when plugged in. So it is recommended to initiate vibration at the lowest setting of 70 hertz frequency and standard setting of 2.5 millimeters amplitude. Place yourself comfortably on a hard surface, lay flat, and relax before turning on the Ferticare 2.0. Apply the applicator pad to the frenulum or dorsum of the penis. Apply modest pressure. If the applicator pad stops vibrating, it is recommended to reduce pressure. It just means you've been pressing too firmly. If you continue to apply more pressure than recommended to obtain the desired result, the vibration output will decrease to less than the chosen setting because of a dampening effect. Too little pressure is also not helpful. To ensure your Ferticare 2.0 is always ready for use, it is recommended to clean the applicator after each use. So to clean the device, simply pull the detachable applicator pad from the vibrator and wash it in warm soapy water. It can be push locked back into place. You may wipe the outside of the vibrator with a dry or lightly dampened cloth. Do not immerse the vibrator in any type of liquid or cleanse with rubbing alcohol. Autonomic dysreflection if the level of injury is above T6. Seek advice from your physician before use of Ferticare if you have any concerns at all. Although no clear definition for autonomic dysreflexia AD exists, it is described as a conglomeration of symptoms, including headache, skin flushing, stomach paresis, illness, and uncontrolled hypertension. It is generally accepted that a sudden dangerous rise in blood pressure is the autonomic dysreflexia to be avoided. To this end, all subjects at risk for AD should take 15 to 20 milligrams of nifedipine sublingually, approximately 20 minutes before using their Ferticare device. So once there were a gamete of unpublished studies, published studies relating to the efficacy of Ferticare 1.0. As yet, there's only one unpublished study for Ferticare 2.0 from the Miami Center to Cure Paralysis, the University of Miami Miller School of Medicine, authored by Nancy Brackett. This study established efficacy in 13 of 15 subjects, 6.6%. Some patients in the study did use a two-device approach. Research previously with Ferticare 1.0 has found that application salvaged 22% of failures relative to failure with one Ferticare device. The message here is that if one device alone fails, try using two together, one on top and one below the glands, as this can slightly increase the odds of a successful ejaculation. So in summary, tips for success: use Ferticare at most once per week to avoid exhaustion of your ejaculatory muscles and the reef, leaving ideally 10 days before use when your partner is ovulating. Lay flat on a hard surface, hips flexed with a relaxed state of mind, with 2 to 3 minutes of stimulation time. Optimal frequency for most patients has been shown to be 100 Hertz at 3 millimeters amplitude, but do of course experiment with the settings. Every patient is different. So Ferticare 2.0 costs £590 sterling net of VAT plus delivery. It is not refundable or returnable when used, I'm afraid. You can zero rate for VAT if you have a Schedule 2 medical condition, such as obviously spinal cord injury, multiple sclerosis, diabetes, or a history of prostate cancer, radical pelvic injury or surgery. There are 12 qualifying conditions in total. A declaration as such for Her Majesty Revenue and Customs. You can order your system from iMEDicare on www.mypelvichealth.co.uk, or simply call iMEDicare Customer Services. Their telephone number is on the website. As a special introductory offer to sex and the spine members, you can purchase Ferticare with a 10% discount using code iMEDFerticare, all one word, applied in the shopping basket of mypelvichealth.co.uk. We also can offer right now live free televideo support on request. So we've come to the conclusion. Thank you very much for your attention. I hope this was useful. We'd like to very much thank Sex and the Spine for inviting us here today.
Darren, thank you so much. That was extremely useful. It's always nice to see the technical details of a product. And Sex and the Spine obviously would like to really thank you for powering this webinar. And to back all of this up, I think it's great you mentioned the 12 different conditions because, you know, as much as because we are more related to spines and we talk a lot of spines, it does not negate the fact that it can be used in other conditions, obviously. And it's good for people to know how this technically works. And there have been a lot of changes that have come out from Ferticare 1.0 to 2.0. And we will obviously hear more about it from Chris's perspective later on. Thank you, Darren. If anyone has any questions, please do write it in the chat box below, and we will address all these questions at the end in the Q&A session. I'd like to now move on to Michelle. Michelle, you've had a number of people, patients, clients you've spoken to who've used this, and it would be great to hear your experience on what you think about it and what your patients or your clients and your friends actually think about it. Over to you, Michelle.
Thank you very much. Thank you. Okay, I have quite a bit of experience of listening to my clients who've come in and talked to me about their experience of using the Ferticare and other vibratory devices. So a lot of useful knowledge regarding how they use it, the effectiveness of that. And also, I think we often forget that with it being classed as a medical device, that it's actually really good fun to use. And a lot of people use it for play as well as for fertility. I know in the spinal units, quite often it becomes very, very medical. And part of my job as a psychosexual therapist is to look at how an individual or a couple relax with the device such as this, because sometimes it can be brought into the room. Sometimes lubricant can be very difficult for people to bring into a sexual relationship, never mind a larger vibrating device. So some of the experience I've had, I had a gentleman that was a high level incomplete spinal cord injury, and found that the device did work for him. This was the Ferticare #1, and it did work for him. But the issue he had was he didn't have very good hand function. So he spoke to his occupational therapist to look at how might he get something to hold on to it with. Now with the Ferticare 1, I think you could hit it. And when you hit it, it actually would come on and off. Now I'm sure Chris will tell us about the newer one, but he was able to, on his own, sort of manage this. So he spoke to his OT, and he got a brace made so that he could hold on to the device himself. But then he found that this was quite difficult. So we negotiated with his care team. Now, first of all, you can imagine the horror of the care team being asked, oh, is it possible to help this gentleman ejaculate? So there was a lot of negotiation went on with the care team, and one of his personal assistants was happy to do this because she understood how it made it easier, because for this gentleman, it reduced his spasms. So it made it easier in the morning to get in and out the shower, to do his morning routine, and all this helped. So when she saw it as a non-sexual device, a non-sexual aid, that enabled her as his PA to think of it as a useful, more medical device. And it enabled him to do his morning routine so much quicker. Now, this was done, this was only one PA that would do that. So this is probably about once a week that this happened for him. But at least he got the opportunity to feel comfortable with it. He was single at that point. And then often later on in a relationship, he felt so much more at ease having the device, knowing how to use it, knowing how to talk to a partner about how they might use it, and then bringing it in to the couple. He was a heterosexual gentleman, brought it into the couple. And I speak to lots of people that use it as actually a masturbating device, not just a masturbating device, but a vibrator for women, a massage for sensation and touch, and how people might feel things. So being able to change the amplitude and being able to turn that up and down, people can play with it. And I think it's so good that people can start to relax with a device like this, and it doesn't have to be for fertility. There was a couple of gentlemen that I worked with who were married, and one gentleman just said, actually, if my partner's going to ejaculate, I want to still ejaculate. And this gentleman was able to do that. And as a couple, they were able to, again, play with that device, play with all of that. There's so much that goes with that ejaculation as well, isn't there? So, partners might want to taste, partners might want to know that this can still happen. And I think often, because the device has been in the past fairly expensive and difficult, as Darren said, to get hold of, I think now it's so much better that people can get hold of the device much more cheaply, but also they can use it. They can use it in so many ways. You get a gentleman, lots of guys at patient education will say to me, I really, really want to be able to know if I can ejaculate. And in the past, that's been really difficult. But actually now we can say, you can get hold of one of these and you can try this out. And that's been very difficult before. I think permission in the relationship is very important. So if you've got somebody with a device like this who is used to using it, literally being able to have a conversation about it. So in the sex therapy that I do, would often bring in this later. So I would talk about sensual touch to start with, how you might move it, and then I would bring maybe the vibrating device in just for touch around the body. Let's have a look at sensation, so it becomes normal within the relationship before actually using it. And some people want to get straight to using it and use that for play. So there are so many different reasons that people might want to use that, and not always medical. I think if there's a claim going through, or case managers are working, I think it's really important to look at this and get this put on the claim. Even if, before it was all about actually you have to be of a certain age, you have to be in a heterosexual relationship, it has to be for fertility, and having things luckily moving forward and changing, I think it's really, really important that case managers and solicitors think about this and add this onto their claims. So, but like I said, the main thing for me is the play, and the touch and the sensation, and hopefully that gives you some idea about how the device can be used safely and fun. So thank you.
Thank you so much, Michelle. I think you bring up some good points there. Darren always tells us, obviously, the device is very big. So there's obviously a lot of reluctance, a lot of fear. Yes, Darren, thank you. So it's true, it's a bulky device, but it works and it's very useful. And on that note, obviously, we'll have a lot more to discuss at the end, Michelle. But on that note, I'd like to move on to Amr, because I think you've worked with so many patients, you're a urologist, andrologist, and you've done this procedure yourself, you've used it. So from your point of view, I don't know, would you be comfortable if I make it a little more question and answer rather than it going?
Yeah, sure. Yeah.
I think it'll be useful for people to also relate to that. In terms of sperm retrieval for ejaculation, what are your thoughts? What are the different methods of doing it? How do you do it throughout along with your experience? What would you like to say?
For people with anejaculation, we have 3 levels of sperm retrieval from a fertility point of view. The first is penile vibratory stimulation, so using the vibrators basically, because it is cheap, relatively cheap, non-invasive, with a good success rate. Like it's going to work in 80% of patients with lesions above T10, providing antegrade ejaculation, as opposed to retrograde ejaculation, which happens a lot with using electro-ejaculation. Another advantage of using the Ferticare vibrator is that it can be done at home, and therefore for the couple seeking fertility, it allows for home intravaginal insemination, which is a great advantage. So you don't need to have IVF, whereas other methods of sperm retrieval, usually we will need to use them for assisted reproduction, like IUI or IVF. So I think it's a great advantage for the couple to first try home intravaginal insemination. Where where the vibrator does not work, then the next step would be to use electroejaculation, which would work in the majority of patients. Of course, with electroejaculation, this needs to be done in theater. Is a transrectal probe that emits electric pulsations that would lead to contraction of the prostate, seminal vesicles, ejaculatory ducts, and the pelvic floor muscles. In patients who are sensate, this would require general anesthetic, and there's slightly a higher risk of autonomic dysreflexia. I only need in patients who do not ejaculate surgical sperm retrieval. I would say only in 3 to 5% of those patients, they would need surgical sperm retrieval. When we do the surgical sperm retrieval, we are limited to IVF or intracytoplasmic sperm injection.
Perfect. Thank you very much, Amr. In terms of patients with spinal cord injury, or even those who have an injury with an ejaculation, what do you think is the best timing for doing a sperm retrieval procedure or use of Ferticare or a penile vibratory stimulation device? What do you think?
I think there are lots of studies that show that there is that people who don't ejaculate, there is deterioration in the motility and the vitality of the sperm, and this starts quite soon after the injury. I mean, within a few weeks or months. So there is deterioration in the quality of the sperm, despite the problem is mainly an ejaculation. But then you have other factors involved due to the elevation of scrotal temperature from the posture, stagnation of the sperm in the male genital tract, which leads to increased oxidative stress, production of anti-sperm antibodies, damage to the sperm DNA, and there's also the recurrent genitourinary tract infections. So what the studies tell us, that there is gradual deterioration in the quality of the sperm with time. So obviously there are no clear guidelines of when you should do the sperm retrieval, but taking those studies into consideration, it may well be a good idea, especially in the younger patients who are not yet considering fertility, to do the sperm retrieval and freeze the sperm at an early stage. But of course, this is subject to discussion with the patient, and you can use the vibrator, obtain several good samples, and cryo preserve them for future use should there be deterioration in the quality of the sperm.
Well, that's very interesting. But just on that point, in your practice, have you seen a lot of patients coming to you early?
I've seen a number of younger patients who requested this to be done early after the injury.
No, that's I've just seen one of the notes from Mr. Mitchell-Tepper where he said he's got some anecdotal data which indicates that a lot of folks are using electroejaculation at home. And he's using external stim with some inexpensive TENS units. Do you see that often too, Amru? Do you think a lot of people do use that at home?
I'm unaware of them. I'm unaware of this, of course, because we use in theatre we use the Sago, which is a transrectal probe, and this is not. I think they are using something that does, if they're using the TENS machine, this is like they're using something that does some sort. In that case, this would not be electroejaculation, because electroejaculation is done by or not conventional electroejaculation. In that case, they would be using a weak electrical current that is applied to the actual genital skin, and in that way, it would act similar to the vibrator. So you're actually stimulating the skin. But the conventional, when we say electroejaculation, we are referring to a transrectal probe that does emit an electric current with a high voltage that leads to violent contractions of the pelvic floor muscles and the muscles of the prostate, seminal vesicles, and ejaculatory ducts. So this is something that can't be used at home. So the system that you're referring to, I think it does produce a weak electric current, but I think it would work via the reflexogenic ejaculatory pathway. So in that way, it is similar to the vibrator. But when we say electroejaculation, this bypasses the reflexogenic ejaculatory pathway and induces violent contractions of the pelvic floor muscles, leading to antegrade. So in a nutshell, the electroejaculation that I'm referring to is exactly like you electrocute something or someone, or electrocute a muscle.
Yeah, I can imagine, because it's like the TENS system that we would use even for spine patients for back pain or for other causes. Not trying to compare, but what I'm trying to say obviously is the frequency that you use or the kind of electric stimulation that you use obviously will be much lower. Otherwise, it wouldn't be something that would be appropriate for home use. So, but no, thank you, Mr. Tepper, for the, he found that very useful. So that's great. Just another, not that I would like to jump into questions, but I think it makes a lot of sense at this point. Amr, in terms of your experience when you do different methods of sperm retrieval, how do you collect them? Because I have a comment from one of the attendees as to them finding it difficult on tip, and if you have any tips for collecting them in terms of a container or in terms of because you need 2-3 people to do it at a time. But do you have any easy tips and tricks when you use it?
It depends on the method that we are doing. So he's referring to using a vibrator.
Yeah.
So if you're using a vibrator, ideally you would need the assistance of your partner, and then collect in a sterile container, and then load it in a syringe, and then it can be used for intravaginal stimulation. But it would be quite difficult if you're trying to do it on your own. So you would need a sterile container, and your partner might hold the container. First of all, of course, you need to clean the actual penis and the meatus. Sterile container with the assistance of the partner. Patient can hold the sterile container, partner can hold the vibrator, or partner can hold both, and collect the sperm or the semen sample in a sterile container, and then load it in a sterile syringe. So you need container and syringe.
Okay. Well, I can see Chris shaking his head.
No, I'm nodding.
With what Amr says. So I'm sure we'll come back to that discussion as well. Amr, thank you very much for that too.
Thank you.
I know we've been talking a lot about sperm retrieval for fertility, obviously in anejaculation. Do you think that's the only benefit or the only importance in this whole, or is it just one aspect of the whole spectrum that we're touching on? What do you think?
I think I agree with you, because most of the studies that looked into vibrators, they were fertility. But as Michelle said earlier, this can be used for sexual pleasure, which is a right for everyone. So everyone should have that opportunity. So even if ejaculation doesn't happen, the use of a home device like the vibrator may allow those men to become orgasmic. And we see that over half of the men, or up to 60% of men with spinal cord injuries, they are still orgasmic. Furthermore, the use of the vibrator in spinal cord injury men during foreplay, in men with preserved T11 to L2 spinal segments, so in men with higher lesions, they would have the reflexogenic erections. And therefore, the use of the vibrator during foreplay will help to promote the erections. So, because many of those men will have, they would have some sort of erections left. And therefore, when you use the vibrator, that will stimulate reflexogenic erections if they have preservation of the reflexogenic erections. So it may help during intercourse, and will also help them achieve orgasm. Another point of view is that another important point is that normally men get nocturnal erections when they are sleeping. So these nocturnal erections are very important in bringing oxygenated blood and growth factors to the penis. If the penis is not getting frequent erections, therefore the penile tissue is deprived of oxygenated blood and growth factors, and therefore there's gradual atrophy and even worsening of the erections. So in other words, men need to be getting frequent erections, even not for sexual intercourse, but from a penile rehabilitation point of view. So from a penile rehabilitation, if the penis is not getting frequent erections, there will be smooth muscles and worsening of the erectile dysfunction. So in my opinion, a home device like the vibrator can be used in penile rehabilitation, helping men achieve orgasm, and before intercourse, helping men achieve a stronger erections. And I think what we need is, via questionnaires, we need studies that address these issues rather than just the fertility point of view. And we need studies that are actually based on patient feedback, because I think there's a gap between what the doctors know and what the patients actually experience. One final thing about, I'm sure you're aware of that we have a few studies. Obviously, it's not solid evidence, but they do suggest that men who ejaculate less frequently are at a higher risk of prostate cancer. I generally think that, obviously, I can't comment on this. There are a few studies, not like, but I generally think that it's unhealthy not to be ejaculating. And this is not related to fertility. You don't ejaculate. This is not related to fertility or sexual pleasure, because if men are not ejaculating, what you have stagnation of secretions. What normally comes out in the ejaculate, you have these secretions stagnating in the prostate, seminal vesicles, and ejaculatory ducts. So this stagnation predisposes to recurrent infections, chronic pain, and formation of stones. So it's exactly like someone with blocked sinuses, because the male accessory glands are very similar to, in my opinion, to the nasal sinuses. So this is like having someone with blocked sinuses full of secretions. So I can't see that this would be healthy in any way. And I think it predisposes those men to recurrent genitourinary tract infections.
That's a great point you make. I don't think there's emphasis given on this. That's why, that was exactly why my question came out, because I think we focus so much on fertility, on trying to retrieve sperm. It's required, but this aspect of it actually being healthy in a way too, which is, it's healthy normally. So there shouldn't be any reason why somebody who has a spinal cord injury or who is less able-bodied should not have an ejaculation if that's going to keep them healthy.
I think the more you simulate the normal physiology or what normally happens in your body, the healthier it is. So if you can do that with the aid of the device, why not? So
that's fantastic. I'd quickly like to jump to Chris, because I think you'll be able to shed a lot more light on your experience with Ferticare 1.0 versus 2.0 versus how you kind of have gone through the experience yourself, and your tips and tricks. And I think there was a question as well for you. If we can address that somewhere down at the end of it. But what would you like to say on this whole topic?
Okay, well, a bit of background about me. I got my injury back in 1993, T3 complete. I've been using the Ferticare vibrators to ejaculate for over 25 years. And I have a strapping 22-year-old son cluttering up my drive with mid-90s Japanese sports cars as a result. It's at the point you made earlier, we were able to conceive at home. The way we worked it was that my wife was checking, when peak ovulation, make a phone call. I would literally come home from work. 2 sessions over 36 hours resulted in conception. So that worked. Oh, and also I got a dose of orchitis when I was in Stoke Mandeville, so I only had 1 testicle. So there you go. So it's possible. So compared to the 1, the 2 is much more robust. It's got a very solid feel. As Darren said, the 1 was hand assembled. And over the years, the glued-on hand grip, the small knob for adjusting frequency, and the screw-in pad on the end all snapped off at one time or another until the thing was basically useless. So I'm very glad this thing has come back up on the market again. It comes in a padded case, which again is a good thing because it's easy to damage this stuff. Its extra weight helped me when applying it to the dorsum of the penis. I like the frequency and control increments as well. They simplify adjustment. When I started using this a year after my injury, I would be physically exhausted at the end of a session, even though I take nifedipine to manage my AD. But over the years, I've tuned my brain to such an extent that I don't feel like I've been 10 rounds with Anthony Joshua anymore. Instead, I'm actually now left with those pre-injury pleasurable feelings, as Michelle was saying about play, as well as feeling positive in terms of my self-image as a man. I still get a certain amount of AD. Typical blood pressure might rise to 160 over 130 after a session. That's with nifedipine. If you don't use nifedipine, which I've done just to experiment, you can go up to over 210 with a 135 and a pulse of 56, so not good. But it works for me now. With nifedipine, allied to visual stimulation, it's positive feedback. Although the connection is broken there, you can still make the connection with your mind. We're very visual creatures after all. As Darren says, there are several steps you can take to increase the chance of getting a positive result. Although we've lost that conventional psychological feedback loop, being in a relaxed state of mind really does make a big difference. Or as Michelle was saying, foreplay, play, sensation, relaxing, feeling like it's fun. That just relaxes you. Even though, you say that, you think, oh, it's because I'm relaxed in my head, I can't. It's still the same thing. Those messages are still getting down there around the corner, as it were. It also helps me physically rested. I found that if you try it when you're fatigued, it seems like the reflex can't reach the same intensity. It just doesn't get there. You get to a point where I've found in the past, it won't go beyond a certain level. You'll get to a point where literally my legs will just be doing this, gently in and out, in and out. I think, okay, there's no way I can get over that final hurdle. So at that point, I would stop wasting your time, in my experience. I've used it successfully in my chair. But as Darren again says, the school of thought of being in a position that triggers spasticity in your local extremities increases success. The fact is, actually, on occasion over the years, I found that simply transferring to a standing frame can trigger spasms intense enough to result in an ejaculation. And that's been triggered, obviously, when my hip flexors have been really stretched up, perhaps because I haven't been standing up as much as I should have done. So anyway, it's good to lie down on a firm surface to stretch those hip flexors with your head and shoulders raised slightly, I would suggest, to mitigate the AD. If you or your spouse can stimulate the hip flexors with massage, it can also help trigger the spasticity and help you become more reactive. Apparently, you can also, I've never done this, but apparently if your spouse partner flexes the heel cord, the Achilles tendon, that's reputed to help with spasticity. I take 40 milligrams of baclofen a day. Apparently and I think I found it myself actually, if you reduce those medications, then that can help the ejaculation, because otherwise they interfere with the spasms that you're trying to achieve, raise to a crescendo, as it were. But of course, check with your doctor. I can't say more than that. So whatever, in a way, if you don't want to do that, go with whatever time of day your body is the least affected by these medications. That's it, yeah. Okay, so this is another thing. Patience is the watchword with this stuff. Don't fall into the trap if at first I don't succeed. Try. Don't fall into the trap of if I don't succeed, try again. It's really easy to exhaust the reflex arc. I know I'm not, as I said before, I know I'm not going to get there. It's my legs like a slow motion hokey cokey. I'll stop then and I'll leave it a day or two before another attempt. What seems to work for me is if I surprise my body by going to 100 hertz and 2.5 mil of amplitude immediately on the underside of the penis. Sometimes I'll get a result in seconds in that way. The usual prelude to a result is a series of sort of kicking spasms around the hip flexors, increasing in frequency. I keep applying moderate pressure, then there is a different, more total body spasm that spread through my groin, down my legs, and ripples across my solar plexus just before ejaculation. Here's a disability dividend, boys and girls. Without the increased post-ejaculation sensitivity of an able-bodied man, I've also found that once at that stage, I can trigger further reflexes, ejaculatory reflexes, if I maintain contact for another minute or two, which helps when you're trying to get everything out there. And as we've touched on before, I do suffer from quite severe spasms as a rule. But after a successful session, they'll subside for anything up to 24 hours, which is absolute blessed relief. And I think highlights how adequate rest between each session is vital as well. That's me.
Oh, fantastic, Chris. It's not so easy to get a first-hand experience of someone who's used it, and your experiences, going through the whole phase of AD, going through spasticity and all of that, and how this has helped you. I think that's great. What I'm going to do is, before I ask you my questions, I'm going to just jump onto the questions that have been coming in terms of, do you have any experience in terms of any techniques or advice once you've started using this, especially with people who may have difficulty with hand function?
Yeah, that's from Julie, isn't
yes.
it? Yeah, I saw that one. Well, of course, my hands work, so I've never had that problem. I would suggest in that case, we're into play. And it's, the guys can work together, good communication. She'll, if she uses the vibrator, Ferticare, she'll get a feel for things, and he'll get a feel for things as well, because there'll be, it's practice, patience. And I think there wouldn't be a problem for her to use it on her partner.
Michelle, do you have any thoughts on that in terms of if any of your clients or Amra for that matter who
absolutely it is the play and that communication about how they want to use that in their space, or finding something, as I mentioned before, finding something that maybe an OT can make to enable the hand to grip around the device. So just really playing with the positions, whereabouts on the bed, obviously being somewhere safe on the bed in case of the spasms, but whereabouts on the bed you need to be. I talk to people about touching each other's bodies from top to bottom. So really playing with all of that, including, you might have, and playing with that maybe not necessarily straight away on the penis. So finding a way of holding that and then putting it somewhere else on the body. How does that move? Because sometimes if the arm isn't going to move up and down as well, how are they going to place that? So all about communication and play.
That's perfect. In terms of, when we do a digital evacuation or a stimulation in a bowel program, some men do report some fluid coming out from the penis. So there's a comment made. Does anyone want to comment further on that in terms of?
You do what, Arina? Could you repeat that?
I'm sorry. During the digital stimulation or in a bowel program, like a manual evacuation, when you do it. So sometimes,
that's physiological, because you have the prostate gland and the seminal vesicles. They are filled with secretions. So what you're doing when per rectal stimulation, the anterior wall of the rectum, this is where the prostate, so if I go PR, per rectal examination, squeeze on the anterior wall of the rectum, I'm literally squeezing the prostate and seminal vesicles. So if they are distended with secretions, you are mechanically expressing those secretions. So this is physiological. Even in men, some men without spinal cord injury, or men who don't ejaculate frequently for whatever reason, when they strain, they would notice drops of secretions, clear fluid coming from the penis. This is when you are straining, you are increasing the pelvic pressure in your pelvis, you are squeezing the prostate and seminal vesicles. And if they are filled with secretions, those secretions are going to come out.
Yeah. Chris, did you have something to add to that?
No, I need to agree completely with that. It's exactly my experience, definitely. Digital stimulation, the anterior wall of the rectum, you'll find some of that fluid and so forth will appear over time. Yeah, absolutely.
And would you all think that would be enough to keep the ducts healthy? I think once you clear off the secretions, would that be sufficient enough to keep the glands healthy? Amra, do you think, or is it still required to further stimulate it via stimulatory devices?
This is different. This is quite passive.
This is the physiological fluid that comes out.
This is passive. This is not full emptying. It's different from when you get the actual. So this is passive. This is just exactly like, this is like not a full evacuation of the secretions. So it's different from what happens when you get an actual reflexogenic ejaculation. So this inadequate.
Yeah, you get a few drops. That's what you're seeing. You're seeing a few drops, aren't you?
Amra, I know we discussed saying that, the earlier the better. Obviously, trying and collecting the quality of the semen that we collect is obviously better earlier.
My opinion, of course, but there are no studies that tell us, because I like to say we have studies that tell us that when you wait, the sperm quality becomes bad. But we don't have studies that tell us what is the optimum time to do the sperm retrieval. But taking the first set of studies into consideration, I think we are better off to do sperm retrieval early, especially in younger men.
Okay. On the same lines, the question that's been asked, obviously, is that, do you think there will be a less possibility of achieving an ejaculation or an orgasm years after an injury?
No, it won't be less possibility. The answer is definitely no. We are talking here about the quality of the sperm. So quality refers to motility, to vitality, to the DNA. When the sperm quality goes down, the likelihood of natural conception via home intravaginal insemination is going to go down, and then you would be more likely to require intrauterine insemination or IVF. But you will always, it's not about ejaculation or retrieval, it's about the actual quality of the sperm that is coming out.
Yeah. Chris, sorry, go on.
Well, I was just going to say that my injury was back in '93. Started on the program in '94, tried for a year in '95, backed off for about a year, conceived in '96, so 3 years after, and used it regularly through the '90s and early noughties. I've had probably about a 10-year gap without access to the Ferticare, and it worked again. How good the sperm is, I don't know, but the reflex is always there. Use it, we lose it.
With both your experiences, do you all know of many men who have significant edema from use of this device? Or
when you say edema, do you mean like swelling up?
Sorry, I'm sorry, Chris. I get a bit careful.
Yeah, I was reading it. He spelled it with an E, not an O.
That's in the dictionary, Chris. Sorry.
You're a doctor. Doctors spell it with an O.
I'm a journalist.
We spell it with an O.
I don't think so.
Okay.
No.
Amru, any thoughts on that?
Of course, you're applying friction, so in theory there may be edema, but I haven't had like significant complaint, especially if you use some sort of lubrication, as Darren indicated. So, but with lubrication, the likelihood of edema goes down. Should you get edema, the easiest thing is to apply arnica cream, something that helps, which is off the counter arnica cream on the shaft.
Okay. Does that have I'm presuming that's a trade name. Does that
arnica
have
is like a group of natural? It's not like it helps. It helps as a group of natural remedies that help. Is readily available. Holland and Barrett roots. It helps absorption of edema. I use it routinely after I perform penile surgery for my patients. So it's not an NSAID, so it's not like Voltarol, it's not a steroid. So it's herbal remedies that help edema subside.
Michelle, sorry, you were going to say something.
Just a question that often I talk to people about using different things for sensations, such as lubricants or oils and creams. So if you have maybe a lubricant on your penis and then you go to use the Ferticare, what's your advice about actually, should there be a lubricant on there? Is it better without one? Amir, Chris, what were your thoughts on that?
I've always used it without lubricant.
If you're going to use it for fertility, you don't want any sort of lubricant to drop in the pot. Okay, if you are going to use it for fertility, that's right. We don't want, because many of the lubricants may damage the sperm. So it has to be away from the pot, or use a small amount if you have to.
Using it for play. Do you think, I don't know, Chris, have you had any experience with using it for play and actually putting a lubricant on there to see what the difference of sensation is?
What, for me or elsewhere on my body?
However that feels, does it change sensation? I'm just wondering about how it feels, how it slides.
As to whether the fertilizer by itself, I guess, whether that happens.
It's not a, yeah, you're right, actually. It's not, it's more subtle and softer, and it's achieving, you know, when we're applying it there, this is hardcore. You're going really hard, and you want to try and, as I said before, surprise yourself and get that reflex. So elsewhere, yeah, with stimulate lubrication, I found it really good. Yeah, going back to the edema thing, I probably had 1 or 2 episodes where I've got obsessed and thought, right, you're gonna come on. And then you get a bit of swelling there and so forth. But it goes down after.
Edema is nothing dramatic. I mean, edema is like if you hit your hands on the deck, you're going to get a bit of swelling. So trauma is a reason for induces inflammation. When you have inflammation, capillaries dilate, so they pump fluid in the tissue. So it's something really physiological. Is no reason for concern. With penile edema, if even you don't want to use anything on it, elevation and massage, if it's a bit excessive, will simply help it subside. But what we don't want is inducing skin aberrations or anything like that. So that's what we do. But edema per se is not a dangerous, there's nothing dangerous about edema in any way.
And I've never broken my skin
because the disc is quite smooth. So
Darren, go on.
I was just going to say, we've had a lot of patients using PVS from various different systems that we've supplied over the years, and there's a direct correlation between, obviously, the frequency of use. The pressure applied is quite important, because if you're slapping the skin as opposed to getting into that kind of undulating pattern with the right degree of pressure, you're much more likely to induce local inflammatory response and swelling and very localized edema that subsides quite quickly. So getting the right degree of pressure is important. And then, of course, the time element in each session. So it should be restricted to just a few minutes as opposed to much more than that. On the lubricant front, we often suggest using Yes WB, which is a water-based lubricant that doesn't dry out quickly, because water-based gels like KY or Aquagel, they dry out very fast, and basically after a minute, there's no point in using them. I think it's important not to use oil-based lubricants like Vaseline or baby oil, because they can damage the device itself. Its components are plastic and rubber based. So I think Yes WB is perfect. We've supplied sachets to patients, and for orgasmic purposes, it does seem to enhance the experience.
Now, I think that's a great point, Darren, because it is useful for people to know to not use oil-based lubricants with this device. I'm very aware of the time. We're almost coming to close of the session, but we've got 3 questions. So if we could quickly in the next 2 minutes try and get that. Darren, since you're on I'm just going to ask you quickly, how important is it to use a hard surface? Because a lot of people who use Ferticare obviously use it for pleasure, and a lot of them use it either on the bed or in a chair. So how much of importance are you actually giving to laying on a hard surface? And especially also you have to keep in mind, very rightly pointed out by one of the attendees, that a hard surface with no skin sensation obviously is a concern. So
well, it doesn't have to be a rock solid surface. It can be firm surface, I think is a better way of saying it. And I think it's linked to Newton's force equals equal reaction. So if you're on a hard surface, then more of that energy is directed into propulsion and the ejaculatory mechanism, where if you're on a soft, cushiony type surface, it's dissipated into the ambient environment. So I just think it helps with the ejaculation process, but it shouldn't be a rock solid surface.
Chris, go on.
Yeah, and as Aaron was saying, a firm surface, or maybe a pillow under your backside to raise your midriff up, which is giving you that hip flexor stretch as well.
For sure.
Perfect. In terms of people who have complete sensory paralysis, the question is, what does an orgasm like, and is it worth preserving for? I can give a short answer, but I'd like to hear it from you all before I jump and say yes. But for those who don't have sensation,
well, like me, for example. because I don't have
So
sensation.
it'll be first-hand experience. Michelle and me can jump back onto the other psychogenic stimulations, obviously, but I'd like to hear it from you too, Chris. Go on.
Yeah, well, as I said before, you know, the physiological thing is that you get a relaxation of your body. You know, you relax completely. And over the years, I've tuned my brain in. So the sensations to begin with were quite acute and arduous. They're no longer like that. Your brain is plastic and it gets into it. So over time and more use, it gets closer to how an orgasm used to be, if you like. So yes, it's different, but it's still good.
Yeah, I think that's what you know, Michelle and me always refer to. That there's always, it doesn't always depend just on what you feel on the outside. There are so many deeper sensations that the brain perceives. Just to get back to that question, basically, there are different pathways. So it's not just one pathway that just goes out from the surface skin. So there are deeper pathways, and there's a lot. You know, that's a complete theme altogether. But in short, to answer that question, yes, it is worth preserving for, because you can still experience pleasure. Doesn't necessarily have to come from the sensation that you feel on the skin. Michelle?
And I would add a point that also the orgasm is a cerebral sensation. So like erection, even many men, like erection, ejaculation, orgasm are three complete separate things. They are related in a way, but they are different pathways. And we refer to orgasm as a cerebral, from an andrological point of view, as mainly a cerebral sensation. And that's just in agreement with what you and Chris just said.
Absolutely. We've gone past time by 3 minutes, but we still have 2 questions because you're coming in. So I'm quickly going to jump to that. Amra, in cauda equina, obviously a lot of patients don't have ejaculation. I don't think a lot of people talk about it, but a lot of patients actually cannot ejaculate. So what is your thoughts?
This is like a lower motor neuron lesion, because here there are no reflexogenic erections. Electroejaculation is going to work, because with I'm talking about the electroejaculation that I do in theatre, like using the Sego machine, because when you're doing electroejaculation, you are simply giving the electric signals that the nerves were producing. So I'm inducing contraction of the pelvic floor. So in that case, electroejaculation should work. Should it not work, electroejaculation should be very successful. If it doesn't work, we can easily do surgical sperm retrieval. And in those men, you don't need to do open surgery. We can do aspiration of sperm from the testicle or from the epididymis, because usually they would be distended, they would be full of sperm. But of course, when we do surgical sperm retrieval, I'm limited to intracytoplasmic sperm injection, or IVF. With electroejaculation, we could do intravaginal, intrauterine insemination, or IVF. So I would try first the electroejaculation. If that does not yield in the same session, I would do surgical sperm retrieval.
And what are your thoughts on penile vibratory stimulation at all?
I think it's always worth trying it first. I meant is if it doesn't work, because most spinal, obviously I'm not a neurologist or a neurosurgeon, but when I talk to my colleagues, the lesions are not like as per textbook. They can be very patchy, very different from one person to the other. It's always worth trying it, and most spinal units would have a fertility, a vibrator. So I would always try the vibrator first and see and see if it works. But in general, people with lower motor neuron lesion, where you have lesions involving the actual areas that are responsible for the reflexogenic ejaculation, it is less likely to work. So with lower lesions, it is less likely to work. But it's always worthwhile trying it first. And again, most units would have a machine that they would lend to patients that the patient doesn't have. You sterilize it and you lend it to the patients to give it a go. If the patient does not want to invest in buying one themselves.
Yeah. Sorry, Michelle, what are you
I
going to
think
say?
it's really important, cauda equina, as well, to think about, well, all spinal cord injuries, but I'm working so much more with cauda equina at the moment. about the pleasure, about relearning. Quite often what we do is we try and go back to having sex the way we had it before our injury. And often it is going to be very different. And there's a lot of relearning to be done about touch and sensation and what we now feel. So with cord recliner, I say I've got so many more patients coming through working with that, and usually that's 2 or 3 years down the line. People kind of ignore it to start with, and then they'll come and talk to sort of the psychosexual therapist or start asking questions later. When they've been given so much hope about ejaculation and using these different devices. So I think it's really important that this information is absolutely out there. There was a lady who asked a question, I think before, was it Lisa? Can the Ferticare help with female orgasm?
Yes, I was just coming to that, and I was going to hit you and Darren with the question, but no, go on, Michelle. You can carry on, and then Darren.
I think you can actually put it directly onto different areas of your body that you might have expected then that it worked on. But actually, my experience has been with patients in that they put it on different areas. So if they're a low-level injury, they can put that really heightened vibration. Say they're sort of T11, T12, maybe slightly incomplete. You can put that vibration on your tummy button, and it will vibrate through the system. It becomes softer. You can put that around your nipple area, just to pick up the vagal nerve. So you can put that between your thighs. So when we talk about vibration from the actual device itself, I think it's important to think sort of outside of where you may have used it before. So it's about playing with the vibration around your body to see what you feel. And I know a lot of people, well, actually on the lower level injuries and cord recliner and the saddle numbness, can often feel that vibration going through into their genital area and talk about how sensual and erotic it feels.
So on the good news front, Reflexonic have developed a female version of Ferticare called Valdivia for anorgasmic dysfunction. So we're looking at marketing it in the UK as well. We're just assessing the potential from different business type scenarios, but it does exist. And obviously the important point is the design of the pad, how it contacts with the body, so that the flat pad on Ferticare is not really comfortable for ladies in that sense. It can be used, but it's not ideal. So Valdivia is customized for the female scenario. I haven't seen it in the flesh, but I've seen pictures. It's pink and purple in color. It looks much more effeminate, and I think we probably will be involved with it in the not too distant future for ladies who are interested.
Yeah, no, I think that would be great. I have just seen it, obviously, but that's why I was going to jump to you to ask you that question. We have one more question that's come in. Amra, I don't know if you want to take this. Does the level of injury have a correlation with the quality of sperm?
No, it's not the actual level. The quality of sperm is affected by the stagnation and the posture. The fact the posture elevates the scrotal temperature and the stagnation of sperm. So in a short answer, to the best of my knowledge, the level of the injury has no impact on the quality. Okay,
that's great. I think we've kind of covered all the questions here. So does anyone have any final thoughts on this? Just alluding to where, in cord equina, and it's not a graph it's from one of the textbooks from one of my bosses in India, where it's a leading spinal cord injury center, and this is from my boss's textbook. Just to, a point that not many people know is that a lot of patients with cord equina actually do not have ejaculation, but they do have sensitivity. And so, as Amber said, that it can always try with the penile vibratory stimulation device and see if it works. But obviously, electro-ejaculation is what works the most times. But if you look at the different spinal cord level lesions, so above T10 is where you can have an ejaculation possible, and it's even in the lesions below, it's partially possible. So going back to the question of whether we should or shouldn't try using a device like this, I think we always should.
I think it should be first choice. Like, use it first and then see what happens. This is how I manage my patients.
Absolutely. I would really like to thank everyone for their patience. My apologies, we've gone beyond 10 minutes, but I think it was important to cater to all the questions. Thank you so much to all the attendees who've joined us today. It's been great. And I want to thank each and every one of you all, Darren, Amra, Michelle, Chris. This was fantastic. I think it's really helped all those who've taken the time to attend this. You know, it would be fantastic if we could do this sometime again. And yeah, I'd just like to say thank you to everybody who's here. And we hope to see you all next time when we launch our next webinar. Thank you once again, and have a lovely day.
Thank you.
Thank you.
Thank you.
Have a nice day.
Thank you.
Bye.
Bye.